Thank you for the invitation, and happy to be here and share our experience, but also to learn from the discussion and other experiences you have. And I really like Martin's presentation with the video and their approach to create a more integrated patient care system. It actually points out the challenge here, but also part of the solution in my mind. I'm going to talk about the Danish experience on access to emergency care, and the short story would be from silos to integrated patient-centered care. You got my contact information if you need to get further information. And also in the end, I have some slides with, but I'm not gonna show them with slides with the publication we made. What I'm going to do in this presentation is the setting, what is Copenhagen Emergency Medical Services, from silos to integrated patient-centered care, the solution, and most important, the patient journey, describe how the patient journey works in Copenhagen, and also experience and results from changing emergency care pathway. And you get additional slides if you want to. EMS in Copenhagen is like the traditional ambulance services, but we also do have dispatch centers or command and control centers, and by that, we integrate a lot of information. We have a lot of data, makes it able to do research, but also have an innovative approach to things. But it's all about putting the implementation into the strategy. Otherwise, it's not going to work. Some of the programs we have had, I just want to mention it because it's not just what we're doing right now. We have a national AED net. We have a civilian first responder program in all of Denmark with 70,000 volunteers. We are using video streaming real time in our dispatch center for the emergency calls, but also for the non-emergency calls. And we also use artificial intelligence and test that in our dispatch center. So the future is going to be quite different from what we have seen the last 10 years. Well, this year we also won the Innovation Award on Digitalizations in Denmark based on our AI work, artificial intelligence. This is the leadership network, EMS leadership, and you can see Martin up at the left side. Ireland, Scotland, Berlin is represented, Pierre Carly from Paris, Helsinki, if you want more, from UK, and also Avichu, Chorus from Madrid, and myself, as you can see. And we're working together to try to define what is the best pathway for patients. Today, this is the emergency care health system in Copenhagen. And I would say we cover 1.8 million people. We have 1 healthcare trust, 6 university hospitals in 9 locations. We are taking care of the health-related 112 calls, the emergency calls. They are triaged by medical dispatchers, and they are nurses and paramedics. And we have medical control on-site by physicians 24/7. All ambulance services are part of the EMS system. We have the same standard operation procedures and medical supervision as well, 24/7. And what I'm going to talk about in this short presentation is our out-of-office services is now part of the EMS, and referral of patients to emergency department are triaged in our dispatch center through a separate number, which is in Copenhagen 1813. So it's different from 112, but it's the same call center, the same dispatch center. We all know the challenge here, growing population, more elderly patients, more comorbidity, higher expectations for services 24/7, demand from patient empowerment, and of course also COVID. COVID made it even more difficult for us for the last 6 months or 7 months. But I would also say it proved in Copenhagen that this was the right solution to have the integrated patient care. Otherwise, we wouldn't be able to control and help the patient in such a degree as we actually have been doing. Because we have set up a system beforehand where you can call one of these 2 numbers in 24/7 and you will be served. So though we have these challenges, we also have the solutions right away with advanced diagnostics and new opportunities, and that requires new solutions. I told you about some of the innovation project, or I mentioned some of the innovation project we made, but I will also say what is most important, the thing that we changed mostly and had, which is an innovation, is how we changed the pathway. It was necessary, change was needed. And now in Denmark, we have probably much more centralized care than in Germany, and even more centralized care than we have in the Netherlands. And that is based on a saying that practice makes perfect, and it's also become less complicated for citizens. So the change we made in Copenhagen, I'm going to talk about that, the major change, the major innovation, and that is also why people come to Copenhagen to see our system, come from different states in Germany, from different countries in Europe, even from Singapore and US and from Australia, to see what is actually going on in Copenhagen and how we reorganize that. And it's not just EMS organization, it is also representative from Ministry of Health coming. We went from silos to integrated patient care. And I just want to show you, these are the most important thing in our system is actually the persons there, but we have to set up the right solution for them. Initially, and the past is what I'm talking about, is we thought we had the patient in the center. They could choose to call whatever number they wanted, call the hospitals, go to the hospitals directly, self-care. They could call 112, 1813, general practitioners, the out-of-hour services in a different time setting, the emergency dentist services, the mental health services. So there was a lot of solutions out there for the patients. However, when you ask the citizens, where, or even healthcare personnel, where would you go with this disease and these symptoms at this time of the day, what would you do? Even healthcare personnel wouldn't know what to do. They knew that there was a solution somewhere, but they didn't know what to do. And that was too complicated. So it was part of a political ambition to change that system, make it more easy for citizens to get access to medical care 24/7. And this is the solution. It's much more simple. As a citizen, you can call the emergency number 112. You'll be connected to a dispatch center. That will take care of you. You can call the other number 1813 24/7 and for any other medical issues. But what's behind this is a black box for the citizens, and they don't need to know it because we as healthcare professionals should provide that solution for them. So what they do is if you call 112 and it's a life-threatening injury or they need an ambulance, and 75% of those calling 112 in Copenhagen will get an ambulance, but 25 won't. So, those calling will get an ambulance, maybe with a physician, it could be lights and siren. We could also send psychiatric mobile care unit. We have a social ambulance and even a helicopter, just like in Germany. And if you call 1813, you will then be provided advice or self-care. That might be enough. Half of the patient calling 1813, they can do with advice and on self-care. And they don't need to see any doctors or nurses or going to the emergency department. We can refer to the general practitioners, for instance, next day. We can refer to emergency dentist care. We can arrange a home visit, sending out a physician for a home visit. Or we can mental health care department, or we can send them directly to a hospital, book a time in the hospital for hospitalizations if it's really needed. And then about 30% of all patients we send to the emergency department for further assessment. And then we, based on the criticality or the needs of the patient or the wishes of the patient, we send them to the appropriate facility and we even book a time for them there. So all what was in the black box was not necessary for the citizens to know. It's the responsibility of the healthcare system. And what is most important is that 112 personnel on 1813 actually have two different protocols because it's two different issues people are calling, but they can change the protocol or they can refer the call directly, for instance, to 112 if they found out that this is an emergency, real emergency, and they need to get advice on specific issues, or they can send an ambulance directly. So it's all linked together when you call one of these two numbers. So just in short, the process of calling is citizen calling, the call is received, there's a conversation, it's triaged to appropriate response. And to give you the example of if the appropriate response, and that might be the case in about 30% of the cases, would be the emergency department, then we refer to the appropriate facility, which means one of the hospitals with that facility that can cope with that medical issue or injury 24/7. So it's depending on the competence and capacity within that emergency department. Then we book a time slot at the emergency department. We actually have scheduled time slots for all emergency department. And we ask the patient, do you want to go to the nearest hospital, or do you want to go earlier and go to a bit far away hospital? We can book a time for you there. Then we send that information to the receiving hospital saying that this patient called us. This is our assessment. The patient needs to be seated in hospital, and we book a time at your hospital at this time. And at the same time, that information is forwarded also to the patient by a text message saying, we booked a time for you at this hospital at this time, and this is how you find your way in, and they will be waiting for you at that time. We can also follow the total capacity and the individual patient journey. So we can see if patients turn up, when they turned up, and if they didn't. And then we also send SMS out for feedback for patients daily to have a following up on patient satisfaction. So that is part of the system. We also introduced video in our system. So we can send a link to the smartphone, and then they can look at the video, or our dispatcher or medical personnel can look at the video. They can also just send a picture if that is what is needed. But video is part of our EMS system, not only for the out-of-hours services 24/7, but also for the 112 protocol. The advantage of our integrated solution is that it is so easy and simple access 24/7 for citizens, for the populations, for any medical need or question they might have. We also have the shortest waiting time in the emergency departments ever. It's a key performance indicator for the hospitals, and it used to be red for every hospital all the time nearly. But now it's green, because we actually book a time in the hospitals, and if there's no time, the patient have to wait, and we'll tell them, inform them, or we'll send them somewhere else. At the same time, we can always put somebody first in line. If we think this is needed, you don't need an ambulance, but if you need to go there to be assessed now, because we're not sure about the incidents or the medical issues, then we can put them forward in line there. Patient satisfaction is 90%. We have an overview of emergency department capacity and ICU capacity as well. And we actually have best use of capacity and resources 24/7. We have control of preparedness and contingency. That means that in COVID, every task ended up in our EMS system, testing, booking time for testing, but also controlling access to hospitals, and some of the things that were taken care of by the general practitioners will also refer to us and to the hospitals. We have transparency in our system, and because we have a lot of data available for planning and patient safety issue, also, of course we do have that. We make mistakes. We are just humans, and but we have full transparency and follow up every case we get, and every complaint we get, we follow up the same day or the next day. And the total cost of the system is lower. It's not adjustment by us, it's adjustment by independent people saying it's lower than it was beforehand. So in summary, for the emergency call, we have 130,000 calls per year. And for the out-of-hours services, the 1813, which is available 24/7, we have 1 million calls per year. Time, two different telephone numbers because time for the first one to be answered is less than 5 seconds. And for the out of our services or the 1813, it's usually 3 minutes on average. But we do have times with longer waiting lists. And then we give the citizen an options actually of jumping the queue and getting first in line there if they think that they are more ill than the other. But they will always be told that if it's an emergency, you will be referred to 112. We have fewer, initially when we set this system up, we reduced the number of emergency department visits by 10%. We have fewer home visits by physician because it's actually not needed in the degree it was beforehand, and hospitalization rates are unchanged. We have an increase in ambulance mission, but that's a national trend, and I think it's lower than expected in Copenhagen. And just to, well, I mentioned the other thing, we have few complaints. We actually have 15 complaints for 19,000 calls per month. Was it easy? No, it wasn't. There were a lot of challenge in changing that system. Though it was a political system, we had very short time from implementation to start. We actually just had 6 months, and that caused a lot of trouble. But that was not the only difficulties we had. There was this traditional thinking in hospital structure, facility, and logistics. For instance, that in personnel in the emergency department, they didn't want us to book a time for the patients because we could do that, overcrowd the emergency department, or we could close them down by not sending patients to them. But now nobody wants to go back to the old system. They want us to take care of the booking and make sure that they are not overcrowded and overloaded, and no patients want to go back to just turning up in a hospital. They want to call and get a booking time or a referral to an emergency department and then be seen faster. We also had a dispute about physicians and nurses because out of our service used to be general practitioners and just physicians, but we also introduced nurses to the system, and nurses actually taking about 70% of the calls, and just 30% of the calls are taken by, handled by physicians. It's not needed to have physicians for all these calls. We can use nurses. And you can dispute that, but there was a publication coming out this year comparing nurses and physicians' performance in quality improvement program, and nurses were a bit better than physicians. And it was comparison of not only what was Copenhagen, but also another system in Denmark. General practitioners in private interest organization also had an interest in that, but that was more about, I would say, prestige and money and power. But I think that most of the general practitioners actually today, we have a very good collaboration with them, and they also like the collaboration we have and how we help them. So, as you know, all the elements are there in your system, in Germany, in Holland, in other European countries. You have all the elements there. You have the different numbers, the different services, the different capacities, emergency departments, and you have the system. So it's actually just about how you put it together. And the train is leaving. The train is leaving all over in Europe and other places for the future. And we have to find out what kind of train we want to jump before it's too late. You can be first mover, or you can learn from other experiences, but there's no way. You have to plan in Europe, in your country, on how to provide better patient care in the near future. So in summary, this was a short introduction to emergency medical services in Copenhagen. We had major changes in our organizations and emergency patient care. It went from silos to integrated patient and centered care. And we have a fully digitalized EMS and healthcare from hospital, or actually from call to hospital and back. So this makes it us possible to control and ensure quality. We are using innovation, data, and research to improve patient care. And I mentioned video as one of them. Another one is that we are now introducing artificial intelligence also to the 1813. So we're going to do that on stroke, and we're going to do that on triage, critical triage. And I think that is the future based on what we have published on identification of cardiac arrest when you call 112. There's a huge potential in using AI to support your system if you do have quality data beforehand. So that's my closing slides, and it takes the system to save a life. You have to build your system in the right way. You have to put things together, and this is why we also in Europe want to learn from each other. So thank you very much.